Alrighty, so today on our Global Spine Initiative podcast, we have myself and Dr. Doug Beall. I am Dr. Anthony Giuffrida, Fort Lauderdale, Florida, interventional spine and pain management. I work very closely with some surgeons down here, and today we're going to be talking about kyphoplasty. So, Dr. Beall, if you give a little introduction about yourself.
Yeah, you bet. I'm Doug Beall. I'm an interventional radiologist. I practice in Oklahoma City. I have a private practice and I'm associated with treatment of vertebral augmentation and practice with spine surgeons at Oklahoma Spine Hospital and also at the Oklahoma Center for Orthopedics and Multi-Center Surgery, Multi-Specialty Surgery. So the topic today is going to be about kyphoplasty. And I think I'll open it up by saying traditionally, this is thought of as taking somebody with vertebral compression fractures and treating them. And the treatment originally it consisted of bracing, rest, analgesics, and some of the other, in air quotes, conservative care. And then going on, and if they don't respond within 6 weeks, then treating them with another treatment consideration. Almost always that's vertebral augmentation, and that is an inclusive term that involves vertebroplasty or kyphoplasty. And so one of the things that the considerations that we have is what the right treatment is for patients whenever they first come in. And I'd just like to open up this topic by introducing the appropriateness criteria, UCLA RAND appropriateness criteria that was put forth by multiple specialties, including every specialty that treats patients with vertebral compression fractures. And so when we insert these expert recommendations, whenever there's no really firm literature criteria, and this was done back a few years ago, back before Medicare started allowing the treatment of acute vertebral compression fractures. And this was done really to follow the expert recommendations because we really had kind of a gap between what we knew to be true and what our clinical experience was as compared with what was in the literature for recommendations or in the LCD for treatment of Medicare guidelines for treatment of vertebral fractures. And so, what this was this is the first time on these treatment recommendations by the experts that people said, well, there's no timeline, there's no time limit, there's no time constraint. It's how severe the symptoms were and how severe the patient's pain function, the debilitation of quality of life, the inability to walk, things like this. And there were elements that said, you shouldn't consider time. You should consider how severe the patient is debilitated because the most common untoward events, adverse events, significant adverse events that happen because of this are related to the patient's debilitation. So each one of these fractures is associated with the rate of mortality of between 8 and 9 times the age-matched controls. And so the last thing you want to do is have somebody suffer morbidity, mortality when you're treating them in a non-surgical management method. So this is one of those times where people said, hey, maybe this bracing rest analgesics as a reflexive treatment really doesn't make sense if the patient can't walk or if they are in severe pain or if they're tremendously functionally debilitated, knowing that there is a high rate of mortality associated with these.
Yeah, I couldn't agree more. I mean, a lot of times we'll hear from other physicians or even insurance companies that the patient needs to fail physical therapy, right? And I understand that for other procedures, but like you said, a lot of these procedures or a lot of these patients that have vertebral compression fractures can't even walk, let alone get through a 45-minute session of physical therapy. So that's always interesting to me. And I think a lot of that may be on some outdated data that where common practice was to brace for 3 months, let it heal on its own. And I talk to patients about this all the time. They ask them, well, will it heal in 3 to 6 months? And, it is a bone. Will it heal? Yeah, there will be some healing over that time, but will it heal completely? I've seen before where I see subacute fractures that still have edema there and the patient still has pain. So I'd love you to touch on that too, if you can, that subacute fracture range, 3 months, 6 months, 9 months, where patient still has pain. What are your thoughts there? Because then there's no more bracing, no more analgesics that can really do any better.
Right. So, there's one of the things that, so patients get treated, let's say they get treated for 3 months. It's 12 weeks. And that's the typical definition of an acute versus a chronic fracture. And they still hurt. And the response is, well, it's healed. Okay.
Yeah.
If it's healed, why does it still hurt? And if it heals, why do you still have transitional pain? So if you break your femur you're not going to be sent to physical therapy because you have a
Yeah,
broken leg, right?
exactly.
If you break your humerus, if you break your tibia, fibula complex, you're not going to be sent to physical therapy. So why in the world are people sent to physical therapy for a vertebral compression fracture? So if you take your fracture, let's say a broken femur, and you take it out 12 weeks, 16 weeks, 20 weeks, and you still hurt, you can't walk on it. Well, they'll x-ray it and probably diagnose you as a ligotrophic, hypertrophic non-union, a fibrous union, something like that. And it's okay, there it is. I can see it. It doesn't look normal and it hurts. That means there must be a fibrous union there. And that's pretty sound logic, very sound in my opinion. So why can't we apply that same logic to the bone that's the vertebrae instead of the
Yeah,
bone that's the femur? And sometimes, as you mentioned, Anthony, there's increased edema, there's stir edema, and there's positivity. And there's a recent article by the guys out of the Netherlands. Paul Lawley is the senior author on this. It's called Vertas 5. It measures pain and quality of life improvements on patients that were gets in vertebralplasty versus sham, and found that there was statistically significant reduction in pain and improvement of quality of life and chronic vertebral compression fractures, and chronic, of course, painful vertebral compression fractures as compared with people that were treated with sham. And there's other articles, other articles that mention chronic vertebral compression fractures and the benefit from that if they're painful. And of course, the bone performs similarly regardless of what type of bone it is. It's not exactly the same weight-bearing, non-weight-bearing, primarily cortical, primarily cancellous bone. But if it doesn't heal and it's still painful, there needs to be some kind of recognition of that. And I think one of the reasons why we allow the treatment of painful acute fractures. I mean, there's data from Bill Clark's Vapor trial that studied specifically vertebralplasty versus sham in acute fractures. There's an article by Yang that says the same thing, comparing vertebral compression fracture treatment with vertebralplasty versus non-surgical management. And then there's newer data, by a guy named Khan, and then we published Emmanuel Husu, the lead author. I'm the senior author on an article published from the Vertebral Augmentation Registry that says not only the sooner you treat it, the better the patient does, but the cheaper it is. And the longer you wait, the worse they do and the greater the cost. So there's pretty compelling data now. And the last piece of data I mentioned is from the Vertebral Augmentation Registry, the largest registry in the world. So not only does it make clinical sense, according to expert recommendations, other author recommendations, but it makes financial sense according to objective things that are measured. If plan A is bracing rest analgesics, plan B cannot be the same thing, especially if the patient's not doing well.
yeah. No, I couldn't agree more. And I think it's very well said. And I always talk to my fellows and residents and say, all right, well, let's think about the procedure we're actually doing and how invasive is the procedure we're actually doing. And it would, to a patient that's never heard of it, it might seem pretty invasive. We're going into the bone, we're putting cement in there. But I think we've come such a long way in the last 20, 25 years with kyphoplasty. The tools have gotten smaller, more precise. The fluoroscopic guidance has gotten better as well. That the risk of the procedures and the invasiveness of the procedures has decreased quite a bit too.
Yeah.
To the point where, to me, it's a disservice to the patient to not just fix it for them and have them go about their way. Patients that do come in with a brace, with a fracture, ask me, when can I take the brace off after the kyphoplasty? And I say, you don't have to wear it out of here. You're done with it immediately. And they say, wow, I've been wearing this for a month or two and I can't wait to get this off. And they go on their way and you see them back a week later and they're doing great. It's one of those things where you look at the procedure, you look at the outcomes, you look at the risks, and you really, got to think about, are we doing the right thing by delaying it all for these kyphoplasties?
Yeah, completely agree. I think people are under some type of delusion that non-surgical management is risk-free and cost-free. Yeah. So we talked about the cost of that. One of my favorite papers on comparison actually took non-surgical management and compared the risks of that versus the risks of kyphoplasty. It was a guy named Liu, published this right before COVID in 2019. and compared the risk and didn't assume that, like, if you take the patient and make them non-surgically manage them, that they're risk-free and it's cost-free. No, there is cost and there is risk associated with it. And when measuring the morbidities of the patients that suffered risk, he found that the risks of doing non-surgical management, the so-called conservative care, was 9 times more risky than
Yep.
kyphoplasty. If you just take all the morbidities that showed up, I mean, there's a whole host of morbidities. Primary ones, of course, are pulmonary, because those are the ones that end up causing mortality. The PEs, pulmonary embolism, and pneumonia. Pneumonia was like 85–90% of the mortalities in the most recent paper we reviewed. But it has to be kept in mind that these things, that non-surgical management certainly is not risk-free, and the concept of bracing can be okay if the patient has low to moderate pain. Maybe they're getting better by the time you've seen them and it's 3 weeks. Okay, that's the patient you treat with non-surgical management. But if the patient has severe pain, if they have severe transitional pain, standing to walk, to sitting, sitting to lying down to sitting up, transitional pain, if they have problems breathing, if they have excruciating pain and difficulty with their functional, with their overall function and their quality of life, I mean, you really need to be considering something else, because that patient statistically will not do well. In the FIT trial, they measured the mortality of the patients that had hip fractures and versus the patients that had vertebral compression fractures. And suffice it to say, it was about the same. And in fact, there's a little bit more in patients that had vertebral fractures in that trial. And it was called the FIT trial. That it was one of treating osteoporosis, and they measured mortality from the major fragility fractures in that trial. And I don't want to imply that hip fractures cause less mortality than spine fractures, but if you take the cumulative data, it's pretty similar. And it's the mortality, almost, as I mentioned, is almost 90% related to pneumonia, or just conditional debilitation.
No, and I think that's a great point, because I think even the general public knows how dangerous, let's call it, a hip fracture is. I don't think that same thought is placed on a vertebral compression fracture, and we need to get that data and that voice out there. And kind of going back to the key pillars of the Global Spine Initiative and GSI is putting this patient back in the middle. Don't let insurance companies guide us. We need to have data that supports what we're doing for the patient, what is best for the patient. And if my surgeon sees a compression fracture, we'll look at it together. He'll say, hey, can you get a kyphoplasty done in there? And I'll say, yeah, we can do that level. If it's a high up level in the thoracic, sometimes a little less pressure, maybe we'll throw a brace on and let's see if it heals. Upper thoracic, let's call it. But lower thoracic, lumbar, my surgeons are very open to saying, hey, let's send it to the pain guys. Let's get this patient feeling better, because they know the data. But some surgeons in our community, I think, don't know the newer data, and that's mortality data. I think we need to go back to that. This isn't morbidity data; it's mortality data, and we can really save some patients from not just the morbidity but mortality from doing a pretty simple procedure. So that's what we're trying to do here: is just get the word out there and hopefully bring together the people that are seeing these compression fractures, right?
I think that's right. I think that's exactly right. If reflecting back to the UCLA RAND appropriateness methodology experience, they had numerous specialties on there: neurosurgery, orthospine, INR, physiatry, anesthesiology. And it's amazing how much we agreed on things. There were high levels of agreement almost across the board. And almost all of these scenarios, not all of them, some of the scenarios were a little bit in the gray zone, but almost all of the scenarios, we had a really good high level of agreement. And so I think that's just it. If you take people that are very facile with treatment across the board, if plan A is bracing, rest, analgesics, be facile with that. Do repeated x-rays, follow the patient up to completion, make sure they respond well to the clinical therapy, make sure the pain goes down, the function goes back up. And also be facile with treating people with vertebral augmentation and doing whatever is necessary to get that anatomy restored back, so where You don't continue to have fractures. Do whatever it takes to treat their underlying disorder, tumor, trauma, osteoporosis, whatever that underlying disorder is, and make sure they have the best treatment outcome. And I think when you gather groups like that together and you ask them, here's a scenario. 75-year-old, think Caucasian female, Northern European descent, 9 out of 10 pain, difficulty with function and quality of life, loss of appetite. It's a T9 fracture, difficulty breathing. I mean, what is your common treatment scenario that you would do in that scenario, in that situation? And people don't have a hard time figuring out what to do, and you make it even a little bit more gray in terms of the equivocal nature of what she has, and it's still fairly clear about what most of the experts would do. So I think the general guidelines and recommendations are lagging. Let me give you an example. The LCD for Medicare says you can't treat chronic fractures. I mean, so
Yeah.
why? Why is that? Is it a chronic fracture that doesn't hurt? Well, no, of course not. If it's a fracture that doesn't hurt, it doesn't come to people's attention. In fact, about half of the vertebral compression fractures that we see are just happening in the background. They're incidental. We don't know that they occur. And the cognitive dissonance is that happens. And there are people that show up with a T6 fracture that have never knowingly had back pain. Then there are people that show up with a T6 fracture that will end up potentially dying from pneumonia related to that fracture unless it's treated. And so all of these are not the same. We have to recognize the cognitive dissonance. There are fractures that don't hurt, and when there are fractures that do hurt, they typically hurt moderate to severe or severe and don't get better. The other scenario is a person that has that severe pain. If they show up to your office 6 weeks after having had the initial onset of that fracture and still just really debilitated, not doing well, the answer is they're not going to do well statistically and based on what we know. So we just have to be able to pull the trigger and go on to the next treatment paradigm. And, I'm a big advocate of, Anthony, as you know, of course, of treating the underlying disorder to, you get rid of the original osteoporosis that led to that fracture and will predispose to other fractures, including a hip fracture. I mean, my mother is in her 80s and she's, as no surprise, a thin Caucasian female of Northern European descent, and she's the absolute poster child for vertebral and hip fractures. And if somebody treated her hip and ignored the fact that her T-score is a minus 3.7 or 3.8 theoretically, well, same thing with a fracture, I wouldn't be happy about that. And I mean, it's there's 85 and there's 85, and if you have a good 85-year-old, that they may have an arguably better life expectancy than my 60-year-old male, 100 pounds overweight diabetic smoker that that has hypertension and that doesn't do what you tell him to. So this is something I think each patient needs to be treated as an individual, and some of the new data needs to be put forth to the CMS, which most of these fractures are in patients that are 65 years old or older. And we need to open this up for some treatment logic to be able to help the patients who need it.
Yeah, I couldn't agree more. I think one thing I tell every patient is, yes, we can fix this fracture very easily, but how do we prevent the next one? Right. And get them on medication if they need to be. Most of these patients haven't had a DEXA scan. Get them a DEXA scan. See where they're at. So I think that's great. And one of the other things I want to touch on is another pillar of what GSI stands on is education and training. And we need to have people doing these procedures that are able to read the MRIs, know that it's not an unstable fracture that has to go to our surgical colleagues and may need surgical stabilization. The training and doing the procedure. I mean, I kind of glossed over for the two of us for kyphoplasty to be on the side of a pretty benign procedure, but that's because if you're well trained at going down the pedicle access in lumbar and thoracic, which is a much different procedure in my mind, a thoracic pedicle access versus a lumbar pedicle access. So that's one thing that we want to push, is making sure that everyone that's seeing these patients, pain doctors, have the ability, because I've also seen it where a pain doctor sees a vertebral compression fracture, doesn't do kyphoplasty. So there only is an option A. There is no option B. They're not working with a surgeon directly, and they're just doing what they can do. So I think that's a big part of GSI is being able to treat the whole patient, either with a colleague that knows how to do the certain procedure, or training yourself and educating yourself and being able to offer that patient that procedure. So I think that's very important. granted, we're doing better with that in the pain world, but there are still a lot of people out there that have done zero pedicle access and are a pain doctor, and same as me and you, right? So that's always interested me that, pedicle access is one of those things to me that differs from someone that just does injections to someone that does advanced procedures.
Yeah, you
And
have
we
to
don't
be
have
able
it.
to refer. I agree with you. I mean, either look, it's okay that maybe you don't or can't do this, have never been trained, but it's not okay that you don't refer to somebody who needs it. And it's okay if you have never done anything, but if you would like to be trained on this, there's plenty of training courses around. There's, training courses by Merit, Stryker, Medtronic. There's training courses that are society sponsored. There's absolutely ways to do this. There are whole books about the subject. One of them is over my left shoulder up here. And there's a bunch of different ways that we are very, very happy to help people train to do this. And it's something that's incredibly important. And in my opinion, it's a very, very simple, it's very easy procedure to do this. The whens and the whys and the how tos and why nots may not be quite so simple, but that's why you have us as continued resources. We'll be happy to try to help as many of our colleagues try to do this. I agree with you. There's the vertebroplasty was first done by a radiologist, a neuroradiologist in France. Believe it or not, the first vertebroplasty was a transoral C2 through the mouth.
Wow.
Yeah, I mean,
didn't know
you
that.
talk about fortitude. I mean, that's I know the guy that did that, and it's unbelievable that was the first one, but it was done to treat a vertebral hemangioma, and
Mm.
that was just proof. But then it was later extrapolated over to stabilization of spine fractures, and I was fortunate enough to start doing vertebroplasty in the '90s, and I mean, it's a Lazarus effect. I mean, you walk in and you see the patients, and they're not better. They're like completely better. They're like they haven't even had a fracture, and I'd never seen anything like that. And I still think out of all the 100 different things we do with the spine and interventional spine procedures, that probably is the best thing. Not only that I do, I think it's the best thing that's done for patients.
I couldn't agree more. I ask my MAs and my NPs all the time, what do you think the best procedure we do is? And they say it's kyphoplasty.
Yeah.
I mean, patients come in wheelchairs and leave without the wheelchair. That doesn't happen with a 20, 30-minute procedure, right? Other than what I've seen in kyphoplasty. And then the procedure is done with the patient awake a lot of the times too, so it's not like it's that invasive.
Yeah,
We're not having.
they try to describe coming in for a spine surgery. I'm like, whoa, 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 that sounds very dramatic and all, and I don't want to run your social media posting. You can call it whatever you like, but any incision that you can't close with a suture or staple, I wouldn't call surgical. This is percutaneous. This is more akin to an injection than anything else.
Yeah, I couldn't agree more. And yeah, so this is exactly what we're looking for at GSI, especially with our podcast, is just have these discussions, talk about how it relates to the pain physician, the physical therapist, the surgeon, talk about how education's needed, and get that information out to patients and get that information out to other physicians. So thank you, Doug. I think this is excellent. You are the world leader in my mind in our field in kyphoplasties, at least top 5 from all the people I know out there. So I really, really enjoyed talking to you about this. And if anyone has any questions out there, you can always reach out to us through any matter at Global Spine Initiative. And hopefully this helps you out a little bit if you have any questions about compression fractures, kyphoplasty, stabilization, conservative care, anywhere along the gamut, let us know. And we're happy to talk about it more.
It's been a great pleasure talking with you, Anthony, about this on one of my very favorite topics in the world. And yes, everyone, as Dr. Giuffrida mentioned, we're good communicators. Please feel free to reach out if you guys are interested in learning more about vertebral augmentation in regard to information and courses and whatever you would like to. We would definitely like to direct you in the appropriate way to get you that information or that training course or whatever you need. Because this will be, if you don't currently do this will be absolutely life and practice changing for you.